Good day everyone. Today we will be discussing about the drug named haloperidol. Haloperidol is a first-generation antipsychotic. Haloperidol inhibits the effects of dopamine and increase its turnover. It competitively blocks postsynaptic D2 receptors in the brain, eliminating dopamine neurotransmission and leading to the relief of delusions and hallucinations that are commonly associated with psychosis. Haloperidol acts primarily on the D2 receptors and has some effect on 5-HT2 and 1 receptors, with negligible effects on dopamine D1 receptors. Haloperidol is indicated in schizophrenia. According to the American Psychiatry Association guidelines, individuals with schizophrenia should possess a comprehensive and well-documented patient-centered treatment plan that aligns with evidence-based therapeutic approaches, and haloperidol may be a component of the plan. In Tourette syndrome, haloperidol is indicated to manage tics and vocal expressions in pediatric and adult populations. In severe behavioral disorders in children, haloperidol effectively treats combative and explosive hyperexcitability, which is not attributable to immediate provocation. Haloperidol should be considered for use in children only after other psychotherapeutic and non-antipsychotic medications have proven ineffective in producing a response. In hyperactivity in children, haloperidol exhibits effectiveness in children presenting with excessive motor activity and conduct disorders consisting of symptoms, including impulsivity, attention difficulties, aggressiveness, mood fluctuations, and low frustration tolerance. Haloperidol is also used in agitation associated with psychiatric disorders, acute mania, chemotherapy-induced nausea and vomiting, and management of intractable hiccups. Extrapyramidal adverse effects observed in haloperidol are acute dystonia, which develops within hours to days of initiation and may manifest as muscle spasms, stiffness, or even ocular gyric crisis. Akathisia is a syndrome that manifests within days to months of haloperidol usage and is characterized by a sensation of restlessness. Neuroleptic malignant syndrome, or NMS. Although uncommon, this severe condition can manifest as high fever and muscle rigidity. Parkinsonism emerges after days to months of haloperidol usage. Tardive dyskinesia emerges after several years and is characterized by coriform movements, particularly in the orofacial region. Common adverse effects are anticholinergic effects, which includes increased body temperature, dry mouth, drowsiness or sedation, constipation and urinary retention. Sedation, weight gain, erectile dysfunction in males, and oligomenorrhea or amenorrhea in females are also observed. Patients with impaired liver function may experience elevated haloperidol plasma levels due to decreased plasma protein binding. Although no specific dose recommendations exist, cautious administration is recommended. In children, haloperidol is no longer commonly used as the primary treatment for behavioral disorders. It might be essential in refractory or complex cases. It is listed in the key potentially inappropriate drugs in pediatrics list due to the high risk of extrapyramidal reactions. Haloperidol is classified as a high-risk medication according to the American Geriatric Society Beers criteria, underscoring the importance of using the lowest effective dose for the shortest feasible duration. Reports suggest that haloperidol can cause galactorrhea due to hyperprolactinemia as an adverse effect. Haloperidol's blocking of dopamine receptors in the tuberoin-fundula pathway leads to hyperprolactinemia. As haloperidol is excreted in human breast milk, lactating women on haloperidol should refrain from nursing their infants. Haloperidol is contraindicated in patients diagnosed with Parkinson's disease and dementia with Lewy bodies, those who are comatose, and in individuals with conditions marked by a significantly depressed central nervous system. Haloperidol should not be used as a chemical restraint to address patient behavior or restrict patient mobility, as it is not a conventional or accepted treatment. This approach should be reserved for situations where the need to address potential violence is crucial to ensure the safety of both staff and patients. In cardiac patients, administering haloperidol intravenously or exceeding the recommended doses of any haloperidol formulation is linked to an increased risk of QTc interval prolongation, Torsades D points, and sudden death. Patients with electrolyte imbalances, particularly hypokalemia or hypomagnesemia, hypothyroidism, pre-existing cardiac abnormalities, familial history of long QT syndrome, or those concurrently taking drugs known to prolong QTc interval require special attention and caution. Thank you. Kindly comment for further queries and doubts.